Well, welcome everybody. This is Allie Orwig with the Indiana Rural Health Association. We appreciate you joining us today. We've got a really excellent program for you, but before we get started, I want to remind you of a couple quick housekeeping items. If you would like to ask a question during today's presentation, you can use either the Q&A or chat function. I will keep an eye on those and act as moderator. You will find those by hovering your mouse either at the bottom of the screen or the top of the screen, depending on which view mode you're in, and you can send a message in. We will hold questions for the end today, but please do submit those as they come up. Also, if you would rather wait till the end to ask your question verbally, we will be able to unmute your line at that time. You will just use the raise hand function, which you find very similarly hovering either at the top or bottom of your Zoom screen. We are recording today's session, so it will be available later this week on our YouTube channel if anybody wants to check that out. And without further ado, I will go ahead and turn it over to the team to introduce themselves.
Deb Nichols, would you like to introduce yourself first?
Yeah, I would, and I've noticed I've got several tiles there, so I'm not sure what's happening there, but I'm Deborah Nichols. I'm the Viral Hepatitis and Harm Reduction Program Director here at the Indiana Department of Health.
Debbie Wallick? Oh, you're muted, Debbie.
Hi, I'm Debbie Wallick, United Way Director in Miami County, which is in Peru, Indiana.
Hello, everyone. I'm Antonia Sawyer. I am the founder of Ship Happens, a zero barrier access point to naloxone, and I am extremely excited to be here with both Deborah Nichols and Debbie Wallick to share with you Building Blocks of Harm Reduction, a community-based sharps disposal program. We have several learning objectives for you today. First, we would like to discuss hepatitis C, and Deb Nichols is going to show us Indiana at a glance. Then we will see the need for expanded proper sharps disposal in Miami County, Indiana, our project development and community stakeholder collaborators to implement this amazing program, project implementation and long-term outcomes that we hope to see within our community, and of course, question and answer session at the end. So first, I'm going to go ahead and hand it over to our amazing Deb Nichols so that she can go ahead and give us a little hepatitis C background.
Yeah, thank you, Antonia. And yeah, thank you, everybody. So really what I'm going to talk about here is some just general Hep C background, make sure everybody's kind of on the same page, and then go through some Indiana data and then a little bit about what Indiana is doing to address the hepatitis C challenge here. So hepatitis C, these 5 questions that are listed here come straight from our Indiana Peer Education Program, ECHO, which is a peer education program that we partner with Indiana Department of Corrections, Step Up Incorporated, and Indiana University, Richard M. Fairbanks School of Public Health. And so this is how our peer educators within the state correctional facilities begin their training for infectious diseases. So the first one is, how do you get it? Hepatitis C is transmitted through blood to blood. And the most common current route of transmission is through shared injection substance use equipment and supplies. It used to be that we focused on the baby boomer population, born between 1945 and 1965. I'll show you a slide a little bit later in the shift in that to the younger population. So how do you know you have hepatitis C? Sometimes you will have symptoms when you first acquire the infection, but most of the time people don't. So if you do get symptoms, you'll look for things like jaundice, abdominal pain, fatigue, headache, a lot of things that could just be anything else, or, you know, maybe feel like COVID now. So really the only way that you know you have it is to get tested. And then also not just antibody testing, but RNA testing to see if you are one of the people that was able to clear the virus on your own. So just because you've been exposed doesn't mean you are currently infectious. So we encourage that testing and then the reflex to RNA. And what happens if you don't get it treated? So if you have a normal healthy liver and you get hepatitis C, you can progress through the stages of liver disease from fibrosis to cirrhosis to liver cancer, and in sometimes cases even die from that liver damage. And can it be treated or cured? This is an emphatic yes. So hepatitis C, we have a cure for it. I can go away from everybody's life really easy if we get the cure in the hands of the people that need it. I won't get on my soapbox here on this presentation. If you want to schedule another time with me, I'm more than happy to talk about that for hours. But one of the things that I just want to make sure people know is that you can get reinfected. So even if you've been cured, if you still have risk factors, you can get reinfected. So how can you prevent transmission? Unfortunately, Hep C does not have a vaccine like hepatitis A and B, but we do have a cure. And so we focus on getting the cure into the hands of people that need it, and harm reduction. So, reducing the risk of getting the infection in the first place. Next slide, please. So what does hepatitis C look like in the country? So this is a map. This is national data. The most recent data that we have nationally is from 2018. And really what these are the acute hepatitis C infections. So these are what we've been able to identify as newly acquired infections. That is what we mean by acute hepatitis C infections. And these are rates that are represented in this map. The area in the red, 5 out of the top 7 states are within the Appalachian region. And unfortunately, in 2018, Indiana did rank #1 in the country for the rate of acute hepatitis C cases. So that's the bad news. We do have some good news here in Indiana. So next slide, please. So when you look at our acute and chronic cases combined, and what chronic cases are those infections that are older than 1 year, means the infection is set in. And is most probably not going to go away on its own. We are seeing a decrease. We saw a peak in 2017, and these are our counts and rates. So the rates are along the right y-axis, and the count of those cases is along the left axis, and it's by years for 2010 to 2019. So we saw this peak in 2017, and we are seeing a decline. So a lot of that increase and then decline is due to the access of direct-acting antivirals, so that cure, and also with the advent and introduction of SSPs in Indiana, and having access to those harm reduction and all of the education that all of our community partners have been out doing. Next slide. So this shows you spatially what hepatitis C looks like in Indiana in 2019. I do want to point out that this map does not show cases for Department of Corrections. So those make the counties look artificially high. But what I want you to focus on here is really where we're seeing the largest burden is along the east part of the United States and southeast part of the United States. And again, don't worry about squeezing your eyes to try to read that. I can get that map to anybody that is interested in it. And then we have overlaid on that our syringe service programs, as well as our non-syringe harm reduction sites. So next slide. So we cannot talk about hepatitis C without talking about the disparities that come along with hepatitis C. So we've been hearing a lot about this over the last year and previously. So I had mentioned before about the shift from baby boomers to a younger age group. So what this graph shows is the year of birth and when we received their first positive Hep C case here in our surveillance system in Indiana. And in 2010, you can see that red line that most of our cases were identified in that baby boomer population. However, once you start looking at later data, we start to see this shift. So in 2019, the majority of our cases are those people ages 18 to 39, which is where we are seeing the increase in substance use disorder. And that's where a lot of those risk factors are in that age group. Next slide. So also talking about racial disparities. So while non-Hispanic whites do have the highest rate per 100,000 population at 72.5, again, this is in 2019, compared to non-Hispanic blacks at 63, that doesn't tell the whole story. So what you also need to look at is at what age did they get their first positive screening? So unfortunately, over the last 10 years, between 2010 and 2019, non-Hispanic blacks had an average of 13 years higher age than non-Hispanic whites at their first time that they received that positive Hep C diagnosis. This translates into being further along on that liver damage continuum that I mentioned in that first slide. So this is a disparity that we also need to address, making sure we're getting screening in the hands of the people that need it. Next slide, please. So what are our top risk factors for hepatitis C in Indiana? And these are data that are reported to our surveillance system. There are a lot of caveats with this data, but really what it is in the counties that we're able to reach people that have hepatitis C and who did report risk factors, 85% were non-injection street drug. And this is the wording that's in the surveillance system. So this is not my wording, and that is being changed by CDC to be more appropriate and less stigmatizing. 83% reported injection drug use, and almost 80% of all of the hepatitis C cases in Indiana reported a current or history of incarceration. And then social contact is the next top risk factor. Next slide. So let's look at this. So, rural versus urban, where are we seeing the largest burden of cases? So again, these are chronic hepatitis C rates per 100,000 population for 2015 to 2019. And really what I just want you to focus on is the rural blue line is on average higher than their urban counterparts when we talk about newly reported hepatitis C cases. And then if you look at the right, you see that same trend in Miami County. So again, we've had that peak and then that slow decline after that, but it's still higher in looking at Miami County than the average in Indiana at their rate per 100,000 population. And again, this does not include Department of Corrections cases because Miami County does have a facility located in that county. Next slide. So what are we doing to address this problem? I know that was a lot of data thrown at you, but let's just talk about the big picture. What are we doing? So we do have universal screenings now. Everyone on this call, everyone between the ages of 18 and 79 should be screened at least once in their life for hepatitis C now. During each pregnancy, so whether or not you have risk factors, each pregnancy, every person with a cervix should be screened for hepatitis C. We have vaccinations for hepatitis A and B. Let's get people out there. Let's get them vaccinated. Indiana in October of last year removed the final restriction for Medicaid. So anybody that is on Medicaid in Indiana and has hepatitis C can be treated. There are no restrictions. There's no provider restrictions. They do not have to prescribe in consultation with a specialist. Don't have to have liver damage before you get the cure. So these are all amazing things that our partners at FSSA have been able to do in working with us and removing these. So Indiana is now one of the very few states that's considered an A+ state with our Medicaid restrictions, or lack of restrictions, I should say. We do have some media campaigns out there. So we have Ask and Act, and there's one picture there in the center that you can see one of the pictures from that campaign. That is a targeted campaign. So if you're interested in using that, just hint, May is Hepatitis Month, so good time to push all of this. And then we've also worked with our partners at FSSA for the Check, Care, Cure campaign. So you might have seen those commercials or heard them on radio. That's going to be running all year long. And then from a division and agency standpoint, we started to work on the elimination plan. So believe it or not, even despite COVID, we were able to finalize the elimination plan. And I'm going to talk about that here in just a few seconds, what that means. And really what we need to do, we need to get the cure into the hands of the people that need it. I know there's cost restrictions. We're working on all of that at the state level. But then we also really need to focus on harm reduction. We need to make sure that we have syringe service program and non-syringe harm reduction programs. So we need to make sure those available and reduce the stigma in using those, because that's the only way we're going to eliminate this disease. And we can eliminate it, that's the thing. Next slide. So the Zero is Possible is our elimination plan. It's our, meaning our state plan. This is not an Indiana Department of Health plan. This is everybody's plan. There's 4 pillars to it: diagnose, treat, prevent, and respond. And I can go ahead and throw in the chat the link to the full plan. And really the whole prevent pillar is surrounded by, or is about harm reduction and syringe service programs. Next slide. So if anyone is interested in being part of the elimination plan and moving us forward to elimination of hepatitis C in Indiana, you can join one of the local zip coalitions. This is a map. So depending on what county you're in or where you have services in, if you're interested in joining, I will also provide that link for anybody to join and be a part of that conversation and a part of that solution. And that is all I have. Thank you.
Deb, thank you so much. That was an impactful and very educational look at what hepatitis looks like across the nation and the state of Indiana. And I think it's extremely important to open up the presentation with that, because it really was the basis and the fundamental foundation on why Miami County chose to do a community-based sharps disposal kiosk program and expand 24-hour, 7-day-a-week access to proper disposal of syringes. It really was first and foremost to address communicable disease transmission in our state. As you saw from Deb's slide, Miami County is above the state average in hepatitis C, and we really wanted to make sure we were doing everything we could to reduce transmission rates for all residents across the county, with 53% being social contact, and then upwards of 85 to 90% being around intravenous drug use or non-syringe using drug use. It was extremely important that we create something that was inclusive of all syringe using residents with a direct target at preventing hepatitis. Secondly, we wanted to work with our street department. We were having an issue with needle pricks for our street department workers. Individuals in the community were improperly disposing of their syringes in trash cans, flushing them down toilets, and they were experiencing about 1 to 2 pricks annually a year, which they were having to report to OSHA and go through the recommended treatment to make sure that they did not transmit a communicable disease. So one of the main reasons why we also needed this was to protect our street department workers and ensure that they were not getting pricked and getting something that we could absolutely prevent happening to them. Lastly, reduce our improper disposal of syringes in community places. And this really is where that building block of harm reduction comes in. Often, if you are looking at implementing a syringe service program or you have tried, you will hear the concerns that there are going to be discarded syringes in the community, that we are putting syringes into the community. How are we going to ensure that we're collecting them? How are we going to make sure that they are not improperly disposed? And this really was an effort to address that, as well as making sure that anyone had access to properly dispose. We were finding them in parks, again, in alleyways, trash cans, and we wanted to make sure that folks had access. This really expanded on our current community-based syringe disposal, which is through our waste district. However, the waste district isn't open 24 hours a day, 7 days a week, and isn't always accessible to folks who might not have transportation. And so we wanted to make sure that we were complementing Samantha's program currently and just increasing access across the board. I want to hand it over to Deb Wallick, who is the executive director of the United Way, to really discuss the Miami County Disease Prevention Working Group that was established in order to implement this program, and then highlight our partners for success, because the members of this working group were catalyst to making sure that this program came to fruition and has been as successful as it has been. So Deb, take it away.
Thanks, Antonia. And Deb Nichols, you did a fantastic job. We thank you for your service. And as Antonia said, we did struggle with this at the beginning, but we're so successful now. So I want to talk a little bit about our initiative partners. We went through a transition period here in Miami County. Our government had a transition. We started 2 years ago, and we started with a mayor and our city government we got new government policy, new government. So we got a new mayor, a new treasurer, a new deputy, new sheriff, new chief of police. And so we had to start all over again. So this is a 2-year process. And so we're excited now. We have a new mayor, a new chief of police. We have a new street commissioner, and we started this with a committee member in the city. And so the Miami County Waste District is on our committee. And so all this has come to fruition, and it's taken 2 years for this to be established. And so doesn't happen overnight. So if you're thinking about doing this, be prepared. It is a long haul, but it is well worth it. So just so excited to be able to say that this has come to fruition, and our community has really taken a hold of this. So the reason that United Way jumped on board is we started our strategic plan, and to look forward to that, one of our major goals was to decrease our risk factors associated with substance misuse and overdose by 25% by 2025. So that's one of our bold goals. And so we partnered with Ship Happens to make this to come to fruition. And so some of our achievements was to increase proper disposal of syringes, decrease sharing the reusing of syringes, needle pricks by the street department, reduce the reports from the police department because they were picking up so many syringes on the street, and some of them were getting pricked. And then I also just described our risk factors related to substance misuse by 25% by 2025. So we have actually hit all of those goals so far, and we're really excited about that. Antonia will share with you our indicators of what we've met so far, and so I won't share anything else. I don't want to burst her bubble on what she's going to share with you.
Thank you, Debbie. Absolutely. So our project implementation really started with developing our working group. And as Debbie mentioned, in August of 19, we formed this working group. And then January 1, we got a brand new mayor, a brand new treasurer, a brand new chief of police. And we thought, oh, this wiped out our working group. And so based off of those working group partners, you can hear how important it is to have local government as a part of the working group. They really are a catalyst. So some of the working group responsibilities are to collect hepatitis C data, collect improper disposal data. That's why the chief of police was very important, because he was going on calls to pick up improperly disposed syringes. And that really is increasing police activity in neighborhoods where it's definitely doesn't need to be. It increases the use of resources that could be reallocated to more emergency type situations. And so that's one of the direct indicators we're measuring. Our street department pricks by OSHA. So again, we want to get that down to a functioning 0. We currently only have street department workers who have reported needle pricks in Miami County. We have no needle pricks reported by any community residents at this time, and we want to keep it that way. So that's another reason why this kiosk was important. Syringe possession charge data. So this is where our prosecuting attorney comes in to kind of identify how many residents in the community are intravenously drug using, how many have possession of a syringe charge, and how can we work together to really destigmatize syringe use across the board in Miami County and start to understand that we have syringe using residents, and that is okay. Whether they're using syringes for diabetes or they're using syringes for drug use, that's okay. We just want to make sure that they are properly disposing of them and they have access to safe disposal. This is really health equity. Everybody deserves to have an opportunity to have access to healthcare and safe use. And so that was really a target for us. And then, of course, plugging them into the program. So each of our working group members provided us letters of support. These letters of support go a long way when it comes to writing community-based grants, when it comes to outcomes and presenting our information and really making this an ethical and credible program for us to replicate across the state. So we had a letter of support from the mayor, from the health officer, from the prosecuting attorney, from our United Way, Ship Happens, of course. And then we presented this to our community first about a year prior to establishing the project, just to make sure we had community voice first, and then we established the working group. So nothing about us without us is a motto we use, and we like to stick to that as much as possible. So we got delayed by COVID a little bit. It delayed us just a tad, but we were all very excited when the mayor reached out to us and said, hey, I see this budget line item in the Treasury report that says if we have an OSHA trained street department worker that we're saving money, what is this budget item for? Opened opportunity to come in and talk with him about the kiosk project, and he picked it up right away. Brought in our new chief of police, he picked it up right away. He also provided us a letter of support and some data, so that was incredible. Once we had all our data collected and all our partners in play, that is when Debbie and I got to hitting the paper and writing grants. And that's really where it's important to have community members, your fundraisers, your United Way. Not only is it in their strategic plan, but they are experts at raising funds and working with the highest risk populations in a community. So they understand who we're working with, they understand why it's important, and they're a great partner to have at the table. So thank you, Debbie Wallick, if I haven't thanked you already for your participation. Finally, September came, a good 13 months after we started the project, and it was time to order our kiosk. I will say it does take about 45 days for this to be delivered from California. So if you are going to implement this project, please account for that. That was something we learned. We didn't know it would take 45 days to come. And so it's extremely important to know that. And then of course we placed our kiosk October 30th. So we got the kiosk and placed it right away. A catalyst in this is also your mayor, because he allows us to place these kiosks on city property. This avoids your not in my backyard mentality of maybe your residential area. This will also avoid having to move it if you were to place it on business property in that business.
And location is the key.
Location is the key, absolutely. And so we have been able to locate city property that is perfect for not only those that are accessing the kiosk, but everyone else around them as well. We want to make sure kiosk using and non-kiosk using participants are all safe, that we're abiding by our driving laws, that we have enough space for vehicles and no one's crossing traffic. There is a lot of technicalities that go into placing a drive-up kiosk, but that's why the street department is a huge partner. They know all the laws, they know where to place it, what property is owned, and they actually place and man our kiosk for us. So they check our kiosk once a week, and when it is full, which it filled up about 20 days after we implemented it. So October 30th, fast forward 20 days, it was full. Fast forward another 20 days, it was full again. And we have successfully collected about 200 pounds of used syringes since October 30th. At 15 grams each, I think a syringe weighs, you can do the math. That's a lot of syringes. So we are well on our way to proving the success. So what are the long-term project outcomes and goals? So I think forward facing, we see a kiosk, we see syringe disposal, but it really is a ripple effect and has so much more impact than just counting how many syringes go into the kiosk. So really this is about decreasing stigma around syringe using residents and increasing community conversation around and buy-in for harm reduction. You heard Deb Nichols in her presentation. Without harm reduction, we cannot eliminate hepatitis. So we need our harm reduction organizations and our harm reduction programs to be endorsed by our communities and by our local government. So first and foremost, decreasing that stigma. Secondly, we want to decrease hepatitis and HIV transmission in our community. Again, we're trying to get to zero, and this is a great way to do that. We also want to decrease the criminalization of the syringe. So this is a huge stepping stone for discussing syringe use in the community. At the kiosk, no one's being profiled. The police do not go around that. I haven't seen one officer around the kiosk since we implemented it. And I think it's, are you going to criminalize everyone at the kiosk for a syringe or no one? And so it really brings to the table a conversation on what our goals are around substance misuse in our community, and if criminalization is really something that's helping us reach that goal. And then increase proper disposal of syringes in preparation for a syringe service program. So again, there is that concern that there will be discarded syringes within the community. And we wanted to eliminate the one-to-one incentive myth for syringe service programs, that you need to have an incentive to get folks to come back to the syringe service program. And by doing that, we have opened up community-based access. So if you were to come to our syringe service program in the future, you would not have to be at a one-to-one, because you could have disposed at any of the 3 other locations in the community. So that was really important as well for us. So Debbie, do you want to talk about the sample letter of support that we got provided by Jeff Sinkovics?
You can go ahead.
Okay. So I just wanted to provide everyone in attendance just a sample letter of what our prosecutor provided us as one letter of support for our grant. We received several of these from other organizations, just to give you some language and an idea of how we were able to gain his support. You can see in there we have some hepatitis C data that does exclude the correctional facility. That was important for him. And as Deb mentioned, that can kind of skew your data. So he wanted to be clear on kind of what that looked like for him. And if we wanted to show him what the kiosk looked like, how it was accessed, and so that he could make a decision. So here is a sample letter of support if you were ever going to need one, or wanted to utilize this one for your community. Okay, now I'll hand it over to Deb, and creating a healthy community starts with us, and kind of talk about this day and what it means to the hospital and to the United Way.
Well, this is the day that we launched our first kiosk, and in the picture over here to my left is Deb. Oh, here, this one here. This is Deb Close. This is the CEO of Duke's Hospital, and then to her right is Shelley Shinneman, just a citizen in Miami County, and then to her right is Adam Sheet, the street commissioner, and she's getting ready to place the first kiosk sharps in there. And her testimony was just incredible. We also had the radio station recording that day, and she just told how she was so excited. She is a diabetic, and she told her story that she has a container that she puts everything in, and she's just so excited now that she can bring them all here. But one thing that we did all of our research about bringing the sharps in, one of the things that we did not understand was that dogs and animals are diabetic, and she has a dog that's a diabetic, and she says she has about 200 sharps that she collects. And we were just floored with this. We just had no idea that animals were diabetics and that we should include them in this data. And so we were just shocked. So anyway, she brought this great big container and started filling it with her dog's sharps and her sharps. And so we were just amazed that we had done all this research and we really had missed out on this component. But, and then so there's Antonia and myself, and this is Connie Cutler. She is with the Miami County Community Foundation, and they granted us the kiosk. So we're so excited to make this day come to fruition, and we just couldn't have done it without the collaboration with the money for the grant, the street department, the mayor, Antonia with Ship Happens, making this all come to fruition with the grants that we've written. And it was just a wonderful day. It was beautiful. And like she said, it took 2 years to get this to come to fruition. It doesn't happen overnight, but we were really excited and we're ready to move forward. Our goal is to have 3 of these by the end of the year. And we already have the money for the next 2.
Thank you, Debbie. Yeah, I just want to mirror what Debbie said, that this did not happen overnight. However, when you think about your syringe using residents, we want it to be inclusive. So when we have Deb saying, oh, my animal syringes can even use this kiosk, it really brings in everyone in the community. And I think that's where the building block is that we've got to get our communities to a place where we have harm reduction at the forefront. And if we can't do it with everyone, then it's probably not going to be as successful as it could be. So really consider your partners, really consider kind of the message that you want to send out and how you can make it successful. And
do you want to talk a little bit about the social media that we got when we posted this?
Oh, sure. So we coined this Prevent Pricks. And it was a really cute billboard that we put up so that we could kind of say, okay, we're trying to prevent pricks in our community. However we do that, whoever's going to use this, that is okay. We had over 138 shares. The entire community embraced this program. It was shared by so many different entities, organizations, and community members. Now, to be completely transparent, we're fast forward 5 months and it got warm one day and it was like, what's that kiosk over there? What? Now we have this, like a patch of people or a pocket of people had no idea it existed, and they kind of threw up a little bit of dust. But then when we took all that positive feedback from the last 5 months and reposted the positive feedback, the folks that were giving us some of that pushback actually came around and said, okay, it is pretty impactful. It's successful and it's assisting our residents. And so there is a lot of positive with this. There is some pushback. It is harm reduction. If you're familiar with the harm reduction space, that's to be expected. But overall, I would say huge success. So far, about 200 pounds of syringes collected. We've been able to present it with here at the Indiana Rural Health Association. We've also presented it for some other folks. Stark County is currently looking at replicating the program. And so we're just hoping that this will result in more communities using this as a building block to establish harm reduction programming.
Antonia, do you have the slide of our billboard?
I think it's on the very first slide or the second slide of this, where we have our objectives, where it said prevent pricks.
So we did 6 months of the billboard slide and got so much good publicity from that. And it was eye-catching. We got a lot of remarks. Exactly. We had board members that said, they about drove off the road when they saw it, but they were like, this is so eye-catching. This is probably the best billboard you had ever done. So we're really excited that we brought attention to the community.
Absolutely. These are Deb Nichols' data sources. And now I'm going to go ahead and open it up for questions. So please, from the audience, if we have any.
So we did get a couple questions. The first is, one person asked if they would be able to get a copy of the slides. So if one of you wants to share the slides and you want to put your email address in the chat, you can do that and people can reach out to you directly.
Absolutely. Yes, we will be able to share the slides.
Okay. Yeah. So if you want to share your email address for anybody, feel free to do that. And then secondly, we did have a question. Where did you order the kiosks from?
So we ordered them from a company called Secure with 2 R's, and I can place the link to their website in the chat. And the kiosk price was about a little over $850 for the kiosk itself, but the freight is that costs nearly $500. So that was something that we needed to consider, that we had to budget for, was not just the cost of the kiosk, but the cost of freight to have it shipped. And also, go ahead, Deb.
Do you want to say anything about the baskets?
I was getting ready to say.
Okay.
And so we also didn't realize that inside the Secure kiosk, there is a 32-gallon drum. However, to purchase another drum of that size is $80. So we had to set up with our waste district that we would line that drum with puncture proof liners that are for biohazard material, and that our street department could take our internal drum, drive it with its lid over to the waste district, and Samantha could pull out that liner inside because it almost came to the point where they were going to incinerate our $80 drum. And that's not a sustainable option for the kiosk if you have to continually replace that every 20 days. So we had to kind of do a little finagling. But these are the lessons that we've learned that we'd be more than happy to sit down and share with a community member or a county as a whole that would be interested in implementing.
Okay. Can you explain again briefly how to gain new community interest, your real first steps?
Debbie, you want to take it or you want me to?
Go ahead. It's fine.
Okay, so this really came from, in 2018, we had attempted to do a syringe service program. That did not get passed. So we had some recommendations from our prosecutor that said, maybe we could place sharps disposal in gas stations or in community places. From that, we published that email and those documents on Facebook and said, what would you think about a community-based kiosk itself? That thread got a lot of attention, and that's where we identified that our street department was getting pricked because their wives got on there and said, we need this. my husband was pricked last year, or, you know, I've been using soda bottles. I'm a diabetic. I have to drive around with my syringes. And so that's really our very first step, was opening it up to our community and getting their buy-in for it. And then taking that community buy-in to our higher level stakeholders for the working group.
Yeah,
Okay.
and this is Deborah Nichols. I just want to add on that is, you know, we have our harm reduction program here at the state, run by Erica Chapman and Sherry Brooks, but it really does start at that community level. And so getting those put together, and again, with the elimination plan, you know, if you have somebody who's just really not sure who the partners are in that area, you know, referring them to the ZIP coalitions, and that is a great way to get started on a lot of these projects and building up those community partners.
And I'll say, I didn't know about the ZIP coalitions until I met with Deb. And I think it would be great for even our disease prevention working group to plug into our regional ZIP coalition, because we already have some momentum and some activities going on that we can share, or even get further ideas for further implementation in our county.
And it was just released. She didn't know about it because it was just released at the beginning of March. So we're still rolling it out.
Okay, could you share some information about the community conversation kiosk program? What training did the street department have to handle syringes safely?
Yes, absolutely. So in working with our treasurer, we identified that by having an OSHA trained street department worker, that the city could save money on their overall insurance for the year annually. And so we reached out to Indiana and asked, you know, do we have an OSHA certified program? Is that what is basically required by street departments to be able to handle biohazard material? So they led us in the direction of an OSHA certification online training program. So our street department worker went through that training. We also provided them puncture proof gloves, so that whether they are on the trash truck or they are managing the kiosk, that we can prevent any pricks by syringes that are improperly disposed, or the ones that are properly disposed. And so he will need to go through that training annually. And that's one person, and he receives a stipend every month for maintaining the kiosk and for kind of being that touch point at the street department. And
that stipend is paid through the city, but the gloves were paid through the grant from our initiative.
Okay. Someone asked, can we get the ZIP locations again? And I am seeing in the chat that we have already included some resources about how to join a ZIP coalition. And then someone who has said that they are a participant in several ZIP coalitions. So you can contact mshort4@iuhealth.org to get into 4, 5, 6, or 9. And then Connor Tiffany is the contact for joining a ZIP coalition, which is ctiffany@isdh.in.gov. Both of those are in the chat. But is there a place to see which ZIP location you would be in?
let me see if I can get mine to go back.
Yeah, and that map is also in the Zip as Possible plan. So if you pull open that link that was posted earlier, there is that map in there as well.
I saw that.
All right, any more questions in the chat or in the Q&A function? And Antonia, don't forget if you want to share your email address in the chat.
Oh, yes, ma'am. Okay, my email is in the chat.
Okay, well, I'm not seeing any more questions come in. Extremely informative and inventive program you guys got in place. Really glad to hear that some communities have already reached out to find out how they can replicate. Just hope that that continues and we can see more of these harm reduction programs around the state. So thank you again, ladies, for your presentation today. This recording will be up on our YouTube channel later this week. If anybody would like to see it again or share it, please please. We love that. Always want to get the information out for folks that weren't able to attend live. So thanks everyone for your attention today, and we'll go ahead and let you go.